Welcome, everyone, to another episode of Surgical Insights. Today, we're diving into a topic that honestly keeps every surgeon up at night: surgical complications. You know that old, grim adage, the operation was a success, but the patient died? It's a stark reminder that our responsibility doesn't just end when we've placed that final stitch and closed the wound. In fact, a great surgeon, truly, isn't just defined by their impeccable technique alone, but by something far more profound: their ability to anticipate, to detect, and then expertly manage the inevitable storm that can, and often does, follow a surgery.
That's so true. Ito apoep we mat hiv action vampa surgery. It's almost like the surgery itself is just the first battle, and then the war for recovery really begins post-op. I think many medical students and even junior residents sometimes focus so much on the technical aspects of the surgery that they overlook the crucial phase of post-operative care and complication management. It's a steep learning curve.
Absolutely. And that's exactly why we need to master this area. For our listeners today, we really want to help you classify complications, thinking about them as immediate, early, and late. We're going to dive deep into the Clavian-Dindo classification, which is such a vital tool for standardizing how we grade these issues. Plus, understanding the nitty-gritty of things like DVT and pulmonary embolism, and being able to spot the dreaded burst abdomen or wound dehiscence, these are all non-negotiables for anyone in the surgical field.
It's a comprehensive list, but each point is so critical for patient safety. So let's start with the basics, Bicho. How do we actually define a surgical complication? Because sometimes what one person calls a complication, another might see as an expected post-op event. Where do we draw that line?
That's an excellent point. Broadly speaking, a surgical complication is any undesirable and unexpected outcome of a surgical procedure that negatively affects the patient's recovery. The undesirable and unexpected part is key. For example, some pain post-op is expected, but debilitating pain not responding to usual analgesia or pain accompanied by other alarming signs would lean towards a complication. We often categorize them not just by what system they affect, respiratory, cardiac, renal, but also by their timing. This timing element is crucial for both diagnosis and management.
So when we talk about timing, we're essentially looking at those immediate complications, then early, and finally late ones. Could you elaborate a bit on what falls into each of those categories? It helps to put things into a practical context.
Certainly. Immediate complications are those that occur literally during the operation or within the first few hours. Think about things like massive intraoperative hemorrhage, an inadvertent organ injury, or even an acute anesthetic reaction. These are usually caught and dealt with right there and then. Then you move into early complications, which typically manifest within the first 30 days post-surgery. This is where you see most wound infections, DVT, pulmonary embolisms, anastomotic leaks, all the common culprits we worry about in the acute post-op period. And finally, late complications can occur months or even years down the line. We're talking about things like incisional hernias, chronic pain, adhesion formation leading to bowel obstruction, or even long-term functional deficits related to the surgery.
That's a very clear breakdown. It makes sense too, because the types of problems you're looking for change significantly over that timeline. So let's talk about some of the big hitters in terms of etiology and pathophysiology. Hemorrhage is always a major concern. Could you walk us through the different types of hemorrhage and why understanding that distinction is so vital?
Absolutely. Hemorrhage is a classic, and knowing its timing can tell you a lot about its cause. We classify it into three main types. First, primary hemorrhage. This is bleeding that happens during the surgery itself. It's often due to inadequate hemostasis or perhaps a vessel was inadvertently nicked. You manage it right then and there. Second, and this is a tricky one, is reactionary hemorrhage. This occurs within the first 24 hours post-surgery. It's often because the patient's blood pressure, which might have been a bit low during surgery due to anesthesia, starts to rise, or perhaps a ligature that seemed secure under lower pressure now slips, or a clot dislodges from a vessel that wasn't properly ligated. It's reactionary because it's a reaction to the return of normal physiology. And then there's secondary hemorrhage. This is typically 7 to 14 days post-op and is almost always due to infection eroding a vessel. The infection causes tissue necrosis and breakdown, compromising vessel integrity, leading to a delayed but often very significant bleed. Knowing these timelines helps guide your initial differential diagnosis when a patient starts bleeding post-op.
That's incredibly helpful. So if a patient has significant bleeding within the first day, my mind should immediately jump to reactionary hemorrhage and think about re-exploration. Whereas if it's a week or two later, I'm thinking infection first. That's a great clinical pearl right there. And another major one, of course, is venous thromboembolism, or VTE, which includes DVT and PE. We hear about Virchow's triad constantly, but how does it really play out in the surgical patient?
Oh, Virchow's triad is the bedrock of understanding VTE, and it's particularly relevant in surgical patients because surgery often ticks all three boxes. You have venous stasises because patients are immobile during and after surgery. Anesthesia also contributes to venodilation. Then there's endothelial injury, which is literally what happens when you cut into tissue during surgery. The inflammatory response can damage vessel linings even away from the surgical site. And finally, hypercoagulability. The stress response to surgery, tissue trauma, and inflammation all trigger a procoagulant state in the body, essentially preparing the body to clot to prevent bleeding. Put all three together and you have a perfect storm for DVT and potentially a life-threatening pulmonary embolism.
It's almost inevitable then, isn't it? Which highlights the absolute importance of prophylactic measures. And speaking of inevitable, infections, they're always lurking. What are the main pathways for surgical site infections?
Indeed. Surgical site infections, or SSIs, are a huge concern. They can be due to a few primary pathways. Firstly, contamination during surgery. Despite all our sterile precautions, bacteria are everywhere and sometimes they get in. Secondly, poor surgical technique can contribute. Things like excessive tissue handling, leaving devitalized tissue, or inadequate hemostasis can create a perfect breeding ground for bacteria. And importantly, patient factors play a massive role. Patients with diabetes, malnutrition, obesity, or compromised immune systems are all at a significantly higher risk of developing an SSI. These are factors we try to optimize preoperatively, but they remain risks.
So it's a multi-pronged approach to prevention. Now let's switch gears a bit. A patient develops a complication. What are we actually looking for clinically? What are those telltale signs in the post-op ward?
Excellent question. Clinical features are our first line of defense. Let's start with respiratory complications, which are incredibly common. Atelectasis is a big one. It's essentially a collapse of lung tissue and often presents as a low-grade fever within the first 24 to 48 hours post-op. Patients might also have shallow breathing. If it progresses, it can lead to pneumonia, where you'd see higher fever, productive cough, and more systemic signs of infection. Early mobilization and deep breathing exercises are key here, which we'll talk about for prevention.
And wounds? What are the red flags we need to watch out for with surgical incisions?
Wounds are critical, obviously. For an infection, you're looking for the classic signs: redness, warmth, tenderness, and discharge. But here's a crucial one for impending wound dehiscence or burst abdomen, which is a real surgical emergency. If you see pink serous fluid leaking from the wound, that is pathognomonic. It looks like diluted blood, almost salmon-colored, and it signifies that the fascial layers beneath the skin have separated. That's your cue to act fast, as the entire wound could burst open.
Pink serous fluid, got it. That's a detail I won't forget. What about DVT? Beyond just pain, what's definitive?
For DVT, the classic presentation is unilateral calf swelling, often with tenderness and warmth in the affected leg. The key here is unilateral. If both legs are swollen, you might think about fluid overload or cardiac issues, but one-sided swelling points strongly to DVT. And just a note for our exam takers, while Hohmann's sign, pain on dorsiflexion of the foot, is often taught, it's actually quite unreliable for DVT diagnosis and shouldn't be solely relied upon.
That's a very important exam pearl. So we've identified the signs, now we need to confirm our suspicions. What are the essential investigations we should be ordering?
Right, investigations. Basic labs are always a good starting point. A complete blood count (CBC) can tell you if there's significant blood loss or a rising white cell count indicative of infection. Electrolytes are important for overall patient status, especially if they're septic or dehydrated. And CRP, or C-reactive protein, is a general marker of inflammation and can be useful to track infection or significant inflammatory responses. For DVT, the duplex ultrasound of the affected leg is our go-to. It's non-invasive and highly effective at visualizing thrombi. If we suspect a pulmonary embolism, which is often hinted at by sudden shortness of breath, chest pain, or unexplained hypoxia, then a CT pulmonary angiogram or CTPA is the gold standard. It clearly shows any emboli in the pulmonary arteries. And for wound infections, a simple swab for culture and sensitivity is essential so we know exactly what bug we're dealing with and what antibiotics it's susceptible to.
So, targeted investigations based on the clinical picture makes perfect sense. But prevention, as you alluded to earlier, Spicho, is always better than cure. What are the pillars of preventing these surgical complications?
Prevention, Spicha, is indeed paramount. The three pillars really are early mobilization, incentive spirometry, and pharmacological prophylaxis. Early mobilization means getting patients out of bed and walking as soon as safely possible. This combats venous stasis, helps lung expansion, and generally speeds up recovery. Incentive spirometry encourages deep breathing, preventing atelectasis and pneumonia. And pharmacological prophylaxis, typically with low molecular weight heparin, is critical for preventing VTE in high-risk patients. These aren't optional extras, they're standard care.
Those are interventions that should be universally applied. Now, let's tackle active management for some of these critical scenarios. You mentioned burst abdomen. What's the immediate action plan if we see that pink serous fluid, or worse, full dehiscence?
Burst abdomen is a surgical emergency, requiring immediate and decisive action. If you suspect or see frank dehiscence, the first step is to cover the exposed contents with sterile saline-soaked gauze. You want to keep the bowel moist and protected from further contamination or damage. The patient should be made NPO Melperos, meaning nothing by mouth, immediately, and prepared for an urgent return to the operating room. In the OR, the surgeon will typically reclose the abdomen using tension sutures, often through all layers of the abdominal wall, to prevent recurrence and provide a strong closure. It's a high-stakes scenario.
That's a terrifying scenario for any patient, and certainly for the medical team. And for the reactionary hemorrhage we discussed, within that first 24 hours, what's the management there?
For reactionary hemorrhage, if it's significant and ongoing, the management is usually re-exploration of the surgical site. You need to go back in, identify the bleeding point, and ligate it definitively. It's not a time for conservative management if there's active, significant bleeding that's compromising the patient. Early recognition and prompt return to theater are key to prevent further blood loss and potential shock.
So, we've talked about complications directly related to the surgery, but what about the broader complications of the disease itself, or even complications of the treatment? These are also part of the post-op landscape, aren't they?
Absolutely, these are crucial distinctions. Complications of the disease refer to how the underlying condition which prompted the surgery in the first place might continue to cause problems postoperatively. For example, if a patient had a severe infection like appendicitis that perforated, they could develop sepsis post-op or even multi-organ dysfunction syndrome (MOTS) due to the body's overwhelming inflammatory response. Or if it's cancer surgery, the disease might recur. And sometimes, these complications lead to long-term disability for the patient. These aren't direct surgical errors but rather consequences of the initial pathology and the body's reaction to it.
That makes sense. It's about differentiating the direct surgical fallout from the systemic impact of the patient's overall health state and original illness. And complications of treatment, I assume that encompasses more than just surgical technique.
Precisely. Complications of treatment are those that arise directly from our interventions, sometimes unintentionally. This could include iatrogenic injuries, meaning injuries caused by medical examination or treatment, perhaps a nerve accidentally damaged during an injection, or even a pressure injury from prolonged positioning on the operating table. It also covers drug reactions, like an allergic response to antibiotics or an adverse effect from pain medication. And a really important one, which often goes underestimated, is psychological trauma. Postoperative delirium, for instance, is quite common in elderly patients, and the stress of surgery and hospitalization can lead to anxiety, depression, or even PTSD in some individuals. We have to be mindful of the holistic impact of our treatments.
That's a powerful reminder that our scope of care extends beyond just the physical wound. Speaking of holistic care and assessment, let's revisit the Clavien-Dindo classification. You mentioned it earlier. Could you explain what it is and why it's so important for surgical audits and communication?
The Clavien-Dindo classification is a fantastic standardized system for grading the severity of surgical complications. It moves beyond just listing complications and assigns a grade based on the therapy required to manage that complication. It ranges from grade 1, which requires no specific treatment or just minor deviation from the normal postoperative course, up to grade 5, which is death. This standardization is vital because it allows us to objectively compare complication rates across different surgeons, different institutions, and different procedures. It's also a great communication tool among clinicians. It's truly revolutionized how we talk about and analyze outcomes.
So, instead of just saying there was a complication, you can say it was a Clavien-Dindo grade 3, and everyone knows exactly what that implies in terms of severity and intervention. That's incredibly useful. And for those studying for exams, what are some of the absolute must-know pearls from today's discussion?
Excellent question, Speecha. For all our listeners, especially those in training, here are some key takeaways that frequently appear in exams and are crucial for practice. Firstly, remember that Clavien-Dindo grade 3 specifically means the complication required surgical, endoscopic, or radiological intervention. This is a common test point. Secondly, reactionary hemorrhage occurs within 24 hours. Always remember that timeline for initial assessment. Thirdly, the most common cause of post-op fever on day 1 within the first 24-48 hours is atelectasis. Don't jump straight to sepsis unless other signs are present. And lastly, a repeat of our earlier point, Hohmann's sign, that pain on dorsiflexion of the foot is notoriously unreliable for DVT diagnosis. Don't base your diagnosis on it alone. You need objective evidence like a duplex ultrasound.
Those are fantastic practical points. They really solidify the important concepts we've covered today. It's clear that while surgery is about skill, post-operative care and complication management are about vigilance, knowledge, and proactive intervention.
Precisely. And that brings us to our summary. The ultimate message here is that vigilance is the price of safety in surgery. Many complications are not only manageable but often entirely preventable. Standardized checklists like the WHO Surgical Safety Checklist are invaluable tools in this regard. They minimize human error and ensure critical steps aren't missed. And of course, careful and continuous postoperative monitoring is absolutely non-negotiable. It's about having that keen eye, knowing what to look for, and trusting your instincts when something doesn't feel right.
It truly is a team effort, isn't it? From the scrub nurse to the senior consultant, everyone has a role in preventing and managing these post-op storms. Thank you, Spicha, for breaking down such a complex yet essential topic into digestible and practical insights. This has been incredibly enlightening.
My pleasure, Spicha. It's a field where continuous learning and critical thinking are paramount. To all our listeners, stay vigilant, stay informed, and always prioritize patient safety. Join us next time for more surgical insights. Until then, take care.